Good afternoon, everybody. Thanks for joining us today for our second in the series of Data to Drive Decisions webinars. We are going to be talking today about resources that are available from the Colorado All-Payer Claims Database that we started early last year during the beginning of the pandemic to kind of chart COVID's impact on Colorado. So we wanted to give you guys an update of what's available. My name is Carrie Frank. I'm the Vice President of Communication and Marketing, and I am joined by my teammates, Maria de Jesus Diaz Perez. She is the Director of Research and Performance Measurement, and Katie Oberg, who is our Healthcare Data Analyst, who is responsible for making a lot of this data happen. So regardless of what you see on the screen, we don't actually have a black shirt dress code at Civic, but we were, for some reason, we're all wearing the same color when we got our pictures taken. So we thought that was kind of funny when we noticed that. Just a few housekeeping items. All lines are muted right now, and we would love to hear from you guys though. So ask questions in the chat box. We may save some questions for the end, depending on if they're relevant immediately or not. So don't feel bad if we don't answer your question immediately. We are going to be recording this webinar, and so everything will be available after the fact. We will send slides and a link to the recording. It'll be posted on our events resource page on civic.org, and we will send it out to participants as well. So the agenda today, we're going to do a quick overview of Civic and the co-APCD in case some of you are unfamiliar with who we are and what the database is all about. We will talk just briefly about what this series is also about. And again, we are going to be talking about COVID-related analysis using the All-Payer Claims Database. Three in particular: high-risk populations for severe COVID-19, the impact of elective procedures cessation that happened at the beginning of COVID in 2020, and then trends that we're seeing in utilization for telehealth. We will have some time for Q&A, and then we'll talk about our future topics in the next webinar as well. So just quick background on Civic. We're a nonprofit organization where we pride ourselves on being independent and objective. And our mission is to advance the triple aim, which is better health, better care, and lower costs. And we do that by providing information, support services, collaborative services to individuals, communities, and organizations. It's all about empowering those on the ground. And many of you are those people that we serve, and it's our pleasure to do that. We, again, serve a wide variety of stakeholders. We think of all of the work that goes into everything that we do as consumers in the middle. So everything we do is to improve the lives of patients and all Coloradans and to lower costs for healthcare. But we do serve, providers, hospitals, employers, nonprofits, a lot of government and state agencies, legislators, researchers, health plans, all of those folks who are striving to make healthcare better. Just quick background of the history of the co-APCD, which is the Colorado All-Payer Claims Database. I will not go into detail on all of these, so don't worry, but it was founded after a Blue Ribbon Commission on healthcare reform that happened in 2018 made the recommendation that we needed a database in Colorado that was based on claims that would help us understand where we had the most opportunities for change in both cost and quality. In 2010, it was enabled through legislation with House Bill 101330. And then at that point in time, Civic was named the administrator by the state's Medicaid department. In 2012, it went live. And since then, you can read through if you have time, but we have been making lots of enhancements to the database. We've added a lot of payers. We've added new capabilities and new analytics, more public reporting. We transitioned to a new vendor that helped us do a lot of that. And our current state is really to continue to enhance and provide more and more information so that we enhance healthcare transparency in the state. So the way that we provide information is both public and custom. So what you're going to be seeing today is a lot of our public data. We have information that will help identify opportunities for improvement in communities through interactive reports and publications, and then things like COVID-19 and things that come up in our state that we make publicly available. We also have a consumer shopping tool that helps patients shop for high value healthcare services and helps providers understand how their prices and quality compare to their peers. We also have another arm of our ability to provide data, which is through custom licensing. And that helps, more of the research community, the state agencies, and people who are looking at very specific projects that need claims data to help inform and advance their projects. So this is, again, the second in our Data to Drive Decisions webinar series. The last one we held was all about what's in the APCD, and all of that information is on our website. If you're interested in looking back at that, it's all about the number of lives that are in the database, what we have for race and ethnicity. But all of these webinars are really, intended to help everybody understand what's available. There's a lot of information, understand the capabilities. And then we also want to hear from you guys. So again, feel free to chat. We want to know if the information that we're putting out there is informative, if there are ways that we can make it better. We do see that this is more of experienced healthcare, even though we're going to be talking, hopefully everyone can understand this. Most of the folks that are probably on the line are more experienced health data users, and healthcare audience have some background in healthcare. And we do these on a monthly basis, starting with the third Thursday of every month from 12 to 1. So always the same time. So with that, I'm going to turn it over to Maria. She's going to talk about our first analysis that we conducted at the very beginning of the pandemic.
Good afternoon, everyone. Thank you for joining us today. As Kerry mentioned, we are going to devote this session to share with you the analysis that we have done to support the management and planning and mitigating the impact of COVID-19, both in the health of Coloradans and also the impacts in the healthcare system. Right at the beginning, March 2020, that seems like is one very short year, but at the same time seems like an eternity ago. We started thinking in which ways we can use the Colorado APCD to inform and to help the health of Coloradans. And we partner with several of our close collaborators in the state, and we have worked for example, with the Division of Insurance to create the analysis of cessation of elective procedures that Kerry will talk about. We partner with CIVHC to make available resources for advanced care planning. We partner with the Office of eHealth Innovation, or work based on their leadership to inform the adoption and strengthening of telehealth services in the state. And we also work, of course, under the direction and guidance of our Civic Board of Directors and also the Colorado APCD Advisory Committee, formed by many experts in the healthcare field in the state. The first analysis that we did was based on this idea of what we can do today that informs the management of COVID, given the nature of claims data. I know that most of you are familiar with claims data, and you know that we don't have data like today data. Our data has some type of lag, and we had to think through that. What is something that we could do that we can use the data that is already in the APCD to inform and produce something of value right now? Could you go to the next one, Kerry, please? So the first analysis that we conducted was in May 2020, or late April 2020, and it was to identify the population at risk for severe COVID-19. If you remember, when COVID first showed up in China and then in Italy, the evidence started to point out that there were some people that were much more likely to develop severe illness from the virus. And by severe illness, meaning that they will go into hospitalization, probably into ventilation and intensive care. The CDC identifies some of the conditions that, based on that evidence, that put people at higher risk. And that was something that we could do using the claims data that we had already for 2019, because chronic conditions, that were the conditions that were for high risk were already there in the population. So we started with the analysis of population at risk for severe disease with the purpose to identify the counties that had the concentration of people at higher risk for severe illness. This was with the intention to help counties and areas to plan resources for that. And at the end, this analysis was used also to plan the allocation and distribution for vaccine. Because if you remember, when at the beginning of the vaccine distribution, that we had very limited resources, and we had to devote those limited resources to the places and people who had the highest risk. So this was a good tool in terms of count of people by county that could help in the definition of how many vaccines and where they are needed. To the next one, please. Okay. We use, as I said before, the definition of high-risk population established by the Centers for Disease Control. This was back in May 2020. So this was based on the evidence that was available at the time. Since then, this definition has changed slightly, but these chronic conditions remain to be true. What they did notably was to add some other chronic conditions that now we know also place people at higher risk. Most notably, to add to this list of chronic conditions, now the evidence has pointed that pregnancy is a risk for developing severe illness. Dementia and other neurological conditions, substance use disorder is another condition that places people at higher risk for severe illness. And also the presence of, if you've had a transplant or if you were a recipient of a transplant, and some others. But the conditions that are identified in the report continue to be true. And also people who are older and people who live in concentrated spaces. The next one, Kerry, please. The way we operationalized the CDC criteria was to use the claims analysis first to identify people that we knew that at that moment were alive. You know that in claims data, we don't necessarily capture all the deaths that happen in a population, but we know for sure of those that happened in healthcare facilities. So we first eliminated those people and made sure to count unique people who were alive in 2019, I mean. Then we identify the primary payer based on primary medical insurance in the most current year. We counted only people living in Colorado and assigned the county based on the most recent address for that member. We counted residents living in nursing homes and long-term care facilities if they had claims in a 6-month period during 2019. And we defined the chronic conditions based on the Centers for Medicaid and Medicare Services chronic condition categories. And somebody was defined as having diabetes or chronic lung disease if they had the relevant diagnosis within the previous 3 years. Next one, please. And we're gonna go and travel to the interactive report because I would like to show you where these analyses are. Okay. But first I would like to just mention that if you go to the main page of CIVHC, just civic.org, you're gonna find the main menu at the top. And we made sure to put all the COVID-related analyses in the first item in the menu. So if you click there, you're gonna find the 4 analyses that we're gonna talk today about. And we're gonna go to the second one, which is the populations at risk for serious illness. And you can scroll up, Carrie, or that, yeah, to the top of the page. So when you go to one of the analyses, probably you're gonna find this and then you're gonna see, oh, where is the analysis? I don't see it. So the first part that you're gonna see is just a brief introduction with an explanation of the purpose of the report and a little bit of context. And then you're gonna find in the right side of the page, we always provide some resources additional to the analysis that you're seeing. In this case, you're gonna look at a Tableau visual, but sometimes you need the data that is behind the Tableau, and you can download the data from the resources on the right. You can also have access to the methodology that has a little more detail than what is explained in the top of the page. And you can also access additional resources that might be useful to use along with this data, like the social distancing index that the Colorado Health Institute produced at that time. That is a very useful resource to give you social context of each of the counties, and other resources. And I'm gonna go to the center pack again. And the second piece, after you have in the top of the page, the purpose, you're gonna find considerations. We also have that section in most of the public reports. And the intention of that is just like things that you need to keep in mind when you're looking at the data. For example, here, it is always good to just remember that the intention of the report is to point out population at risk of developing severe disease. It's not about people having tested positive for COVID or people who are at higher risk of transmission. It's people that, if infected, have the risk of developing serious illness. The other thing that you need to consider when you look at this data is that the data included here is only people with coverage that live in the Colorado APCD, and people with coverage during the year, which was 2019. Just to mention that other factors like the social conditions of these populations are not considered in this analysis. We are only talking about medical vulnerability, but we know that social conditions have placed populations at higher risk for contracting the disease first, and then also place them at higher risk for not having access to prompt treatment and therefore developing worse outcomes at the end. And when we go to the, finally arrive to the report, you're gonna see that we have two tabs. The first tab is the map of the state of Colorado, with one number there that is statewide, 34%. That means that 34% of the population, the covered population in the state, was at higher risk of developing severe disease in the state. And then when you look at the distribution in the state, you look clearly that some of the counties are darker shade, meaning that they have a much higher risk in terms of the population who lives there. For example, Fremont, the population goes up to 44%, while if you go to Garfield or some of those counties in the West, they have a much lower percentage of population at higher risk for developing severe COVID. In this analysis, you can choose by age group. You can also change to look at male, female, or look at specific payer types like commercial payers, Medicaid, Medicare Advantage, or Medicare fee-for-service, which of course they are going to be at much higher risk because, you know, is 65 and older population. And then if we go to the second tab, oops. Let's say you are joining us from one of the counties, one other county, like we have here Adams County, but we can choose just any other county. And you would like to see a little more detail for your county and how your county compares to the state. Here we have detail in terms of by age group, what is the presence of the different chronic conditions. One thing that we observed also when COVID hit the hardest in the state is that populations that were younger were also developing severe disease because they had a higher prevalence of chronic conditions. And you can see that clearly that if you look at the state, for example, in the group of 45 to 64, you have high prevalences of different conditions like diabetes or chronic lung disease that were also high risk for severe disease. We're not going to travel more in this report right now, but I invite you to look at it and play with it. And also now, of course, we all know that we are not done with COVID. Unfortunately, this is going to continue, but also think of this report and this analysis as a resource for other things. Let's say that you are in a county somewhere and you would like to have some data points about some specific chronic conditions. here you can find that. You can find the percentage of people with diabetes in your county and compared to the diabetes of the state. You can find the percentage of chronic lung disease or end-stage renal disease in this same analysis. And you can use it independently. It doesn't have to be only for COVID. This analysis provides information for other sources, for other topics also. And what it is important also to mention here, that what we found, of course, is that the highest population at high risk is the 65 and older, and the second condition that puts people at risk, most prevalent, is chronic lung disease. Mostly rural counties in the southeast, and as you look in the map, where the counties at the highest risk for developing COVID, serious COVID, I should say. And that's all I have about this analysis, but please go look at it and play with it. And if you have questions, feel free to reach out to us, and we'll be happy to hear from you. Thank you. And I'm going to pass it to Katie. No, Carrie.
Thank you, Maria. I appreciate it. Yes, and as Maria mentioned, this is, relevant beyond just COVID-19, but we are talking already about updating this to expand services or expand conditions and add to it. So if you guys have suggestions on ways we could improve upon this or things that you would like to see moving into the future, please let us know. And feel free again to chat any questions that you have in the chat box. I'm going to talk just briefly about our elective service cessation of elective services. Easy for me to say, or apparently not. But before I go back to the slides, I just want to show you really quickly, because there isn't an interactive report on this. But again, this lives under our COVID-19 tab, and it's this potential impact of the temporary cessation of elective services. This does not have an interactive report, but it does have the same considerations as Maria mentioned. And it does have an infographic highlighting the major things that we see in the data. But this is a downloadable data file, and I will tell you all of the goodness that's in it. And there's a lot that you can glean from the data file, but just so you know where that lives. I'll go back to our presentation. So as many of you are acutely aware, especially those of you on the provider side, so beginning in March, on the March 23rd, Governor Polis issued an executive order to stop all elective and non-essential procedures. At that time, it was unknown what the impact might be financially for providers, unknown what the impact will be on patients. And that is something that we aren't addressing with this analysis, but that is possible now that we have claims from 2020, and definitely something we're interested in looking into. But this was a direct request from the Division of Insurance. They were getting ready to receive the annual rate settings for premiums from the payers, and they wanted to understand, based on these 2 months of cessation period, obviously payers weren't paying out as much in terms of claims because a lot of people weren't going to seek healthcare access during that time. So what would the financial impact be on payers that were not paying those claims? And then likewise, it does inform the financial burden that also providers and facilities, other types of facilities, were facing. Procedures in this that we identified as elective include both inpatient and outpatient surgical and diagnosis procedures, such as gastrointestinal endoscopies. And the data, again, is available for download. We included the link in this, and you'll have that in the slide deck later. So a few things, nuts and bolts about the actual analysis. Katie is the one who pulled this together. So any detailed questions she'll be able to answer. But part of the order made it exempt that critical access hospitals in rural areas didn't have to abide by the cessation order. They wanted to be able to still enable access to care in rural areas if needed. And so we did separate out from the main piece of data in the main tab that we have available in the downloaded file does not include critical access hospitals, but we did provide critical access hospitals separately, just because we know that there probably was going to be some decrease in use in those rural areas, even in spite of the fact that the cessation order didn't apply, just because of patients being reluctant to go seek services. So what we did, and this is another retrospective, because we didn't have all of the claims for the actual period of March and April while we were doing this. We looked at 2018 and 2019 data, and we wanted to look at the same time period. So we pulled data from January to June of those 2 years. And then we also provided month-by-month comparison so that we could see, because we know that healthcare access is seasonal, and so there will be some ebbs and flows. We looked at all payers, and including commercial, Medicaid, Medicare Advantage. Just a note, when we did this, Medicare fee-for-service was only available for 2018. So when we show kind of the summary of what we found, we are only looking at 2018 data. We also were able to break it down by things that were definitely elective procedures only, but there is no, straightforward, what's elective, what's not. And so there are some that are potentially elective, could be considered elective, but maybe not. And so we also have a category that combines elective and potentially elective when you look at the data. And then we broke it down by claim volume, and then total paid amount, which is both the member or the patient paid amount and the plan. And then we also have it broken down by just what the health plan paid. And then in the next level of analysis, we did break it down into the types of facilities. So we have inpatient, where we're showing both the facility cost and professional, which is what the payments are to the healthcare professional, and then outpatient, both on the facility and professional payment side as well. And then another category of ambulatory surgery centers and other freestanding centers and diagnostic centers. So this is pieces of the infographic that we've pulled out for you guys, just to see some of the high level information that we found. Elective procedures are significant in our state. Total payments per month, when you combine both the patient portion and the plan paid, is roughly $203 million per month that typically get paid out. It represents 73% of all of the total claims that we see in the database. And it is a significant percentage of all payments made to providers and facilities, around 63% of all payments. When we look at those breakdowns by the actual type of facility, the inpatient is the least impacted, which is not surprising. Hospital settings tend to be things that have to happen. So cost in terms of what the payments are to hospitals, typically on the elective procedure side, is roughly 24% of their total payments. But it does represent about 28%, almost 30% of all of the services that they provide. When you look at outpatient, just the doctor payments or the provider payments, it is a lot higher. So about 78% of all payments that typically go to providers on the outpatient side are related to elective procedures. In terms of utilization, a little bit less, 72%, but still very significant. And when you look at ambulatory surgery centers and freestanding diagnostic centers, they had the potential to be hit the hardest in terms of payments. It's nearly all of their payments at about 91%, and 94% of all of their services that they provide are considered elective. So not a lot happening for them. But in total, I think the bottom line is that this did have a big impact on facilities and providers in terms of potential lost revenue. Just for the 2 months of that cessation period, we estimate $406 million in decreased payments during that time. So we have not updated this information yet, but Katie's actually working on figuring out what that actually looked like in 2020, and not just during those 2 months, but then also what does it look like as we have started to open back up. After the cessation was lifted, we know that patients didn't start running to the doctor, and that's a slow uptick. And then you'll see some of that in in some of the analyses we're going to show you related to telehealth and some of the things we're planning for the future to show that gap in utilization. And I think there's some really exciting things that we can do to understand, again, the impact not only on providers, that's super important, but we also want to know, how many patients were not visiting the doctor, especially, back to Maria's presentation. There's a fear that a lot of patients with chronic conditions weren't getting their preventive care, and they weren't getting their medications and things like that. So a lot of analysis that we can do that are possible now that we are starting to have a full 2020 year of claims. So with that, I'm going to turn it over to Katie to talk to you guys about our telehealth analysis.
Thank you. So telehealth is sort of one of the other big themes from 2020 in terms of healthcare. It's definitely a question on a lot of our minds. But we were specifically tasked by the Office of eHealth Innovation to try to understand how telehealth services are impacting and interacting with our broader healthcare system, both to try to establish a baseline pre-COVID, look at that early 2020 March, April peak when we had the stay at home order. And then now that we are sort of quote unquote post-COVID, looking at what the trends are looking like now, what sorts of services are sort of reverting to, again, quote unquote normal, and what sorts of telehealth services are continuing to be used by Coloradans. And similar to the high risk population analysis, this is just important to make sure that everyone is receiving access to the resources that they need to receive care. And just two quick definitions to go over. We do want to make sure that we are describing the difference between telehealth and telemedicine. Telemedicine is sort of what instantly comes to mind when you think of telehealth. These are real-time synchronous interactions between patients and providers, either over the phone or through Skype or Zoom. But telehealth can also include other services that are not necessarily real-time and are asynchronous. This includes things like remote monitoring, as well as any sort of store and forward transfer. So if you send your doctor a test result or a picture of something and they get back to you later, that would not be considered telemedicine, but we are still including those services in our report. Also, notably, CMS includes transitional care management as part of their definitions. We have included that in our reporting as well. And sort of the question we started out at the outset is a super broad question. So we have looked at the data, lots of different ways to try to answer different questions about telehealth. The first big question is really who is using it, both in terms of where patients live by Colorado County, what the demographics are like in terms of patient age and patient gender, and what sort of coverage these patients have. So commercial, Medicaid, Medicare Advantage, and Medicare fee for service, looking at things by that payer type. And then sort of on the flip side, we're also interested in the provider side. So who is providing telehealth, looking at summaries by broad provider types. Why are people accessing telehealth, looking at the diagnoses that are on these claims. And then lastly, sort of how are these services being provided? So what types of services, what types of visits are we seeing most frequently in the data? And then sort of this is just showing an overall increase, obviously. So this is comparing the same 5 months, March through July of 2019, to the same 5 months in 2020. And we're seeing a probably not surprising, but very dramatic increase of almost 4,000% compared to 2019. And the other thing to note here is that we are seeing that in 2020, Medicaid is paying for over half of the services. And then getting into sort of why are people accessing telehealth, I think this slide is very interesting. We see in 2019 that far and away mental health is the top reason for accessing telehealth. And we see that in 2020 as well, except it's even more dramatic, where over half of the telehealth services provided for this time period in 2020 were for mental health and behavioral health type conditions. And then looking at things from the provider side, we see that the majority of telehealth in both 2019 and 2020 is provided by either a primary care doctor or a behavioral health provider. But then sort of in line with what we were looking at in the previous slide, we see that behavioral health has surpassed primary care in 2020. And then one other thing that is interesting about this view here is that while those two provider types are still the top two, they only account for 57% of services in 2020, as opposed to accounting for 71% in 2019, which I think just speaks to the really wide, diverse array of providers that adopted telehealth in 2020. So we're seeing just a lot of different types of providers who are now using these services now. And now we're going to get to the very fun stuff in the Tableau. Awesome. So similar to what Maria was showing before, we have the similar sort of layout where we have the overview, the insights. There is a very detailed methodology document included in the report resources if you're interested in more nuts and bolts about how we built this report, as well as a lot of these insights, which I definitely borrowed from for this presentation. And then I guess just going down into, oh yes, and we do have a form to download the underlying data for this report as well. And the similar infographic information, which is what we were looking at before. And then this sort of overview summary is sort of touching on those questions that I was mentioning in a previous slide, where we are just trying to bubble up the high level answers to those questions of like who, why, how are services being provided. It's important, I think it's just from this view, this is getting into all of the details that we're sort of including that you can filter by. So here, this is for November 2019 through July 2020, but you have the option of going as far back as January 2018. You can filter by payer type. You can filter by the different telehealth service categories that I was describing previously. Most of the volume is in that telemedicine category, but you can look at the other sort of flavors of telehealth separately. And then the last filter, all of this is currently sort of ranked and summarized in terms of services, but you can look at things in terms of cost. It looks pretty similar, but if that's more what you're interested in, you can filter by that as well. And you can also filter by county if you are really interested in what's driving either a high or a low rate in a particular county. I guess one other insight that I would highlight here is that we do see that females represent about 60% of the telehealth services, at least for this time period. So that's something to keep in mind. And the top services here are evaluation and management services, which are your typical office visits, and psychiatry services, which really go hand in hand with the top providers, who are your primary care providers and behavioral health. So there's a lot of information here. Yes, we can go to trends. So this is, again, this lovely dramatic trend line. You can choose a lot of the same filters. We see this really high spike in April of 2020, and it has started to slowly decrease a little bit, but nowhere near what it was like sort of pre-COVID. So we'll see how that trend line evolves as we add more data to this. But I think sort of touching on the behavioral health theme, one really interesting view of this is if we look at commercial members who are accessing telehealth from behavioral health providers, we see that we do have sort of a spike in April, but this line has continued to increase. So that rate is still going up. So we're definitely going to keep an eye on that one for sure. And I think sort of the last view that I will touch on very, very briefly, sort of below this one. This is just getting into a lot more details if you are really interested in a particular, I guess, type of telehealth service. So this is a lot of the same information that was included in sort of the first summary tab. But now we can look at top 10 in all of these different procedures, diagnoses, and provider types. You can also hover over any of the values and see the trend in that particular sort of subset of telehealth, which I think is really important. And you can also click on anything and filter the entire view by that. So here, if we look at this, this is saying that, let me wait for it to load for a second. But you can filter, you can see that, so for behavioral health providers who are providing psychiatry services, 99% of those are for mental health conditions, which I think is not very surprising. But this is really sort of getting into the weeds of the who and the what and the how. So you can really drill in very deep, and you can also add even more filters and get even more granular into what you're looking for. So a lot of information here to really go crazy with. And I think that's all I have on sort of the public-facing Tableau side. Again, like I mentioned, the data is available for download, and just to be aware of some updates that are coming, we do receive sort of regular refreshes of our claims data, so we will continue to update this report as we receive more information. And then we also have a sneak peek of just adding some context to this report, where if we go to the next slide, we have a little sneak peek of this. So right now our report is really only focusing on this sort of green telehealth section that's in this graph here, and we see this crazy increase. But if we zoom out, if we add more context, and we also look at the in-person visits, this is looking at those office visits in particular, we see that despite this crazy increase in telehealth in April, there still is a net decrease. And while telehealth is starting to decrease after April, there's a net increase because more people are going back into the office and seeing their providers in person. So more to come on this, but we're just hoping to sort of add sort of the bigger picture around this with upcoming versions. And I think that's all I have.
Thank you, Katie. Again, we would love to hear from you guys, and this is again in draft form. This is not interactive right now, but the interactive version, when you hover over some of these, it actually tells you the change from the year before. And likewise with this is the in-person as Katie mentioned, and these are all services that have a telehealth opportunity. So we eliminated services that can't be performed, via telehealth, so that it was actually an apples to apples comparison. But we would love to have input on if there's other things that you guys might want to see from this report as we're in the development stage. Again, we would have the same filters as Katie mentioned with the telehealth, where you can choose the different payer type. You can look at different types of telehealth services, different provider types, and both cost or utilization. But I think it's going to be really important to compare, as Katie mentioned, like we would want to see ourselves probably getting back up to levels pre-COVID. And as we develop this report, we'll probably be able to have the full view of 2020. So it won't just stop at September. So we'll see if that is going up gradually. We would hope that that's going up, especially for important things like preventive medicine, which is one of the drop downs that we have here. So any feedback that you guys have, like now, you can chat it to us, or feel free to send us an email. We have our information at the very end, info@civic.org. But we do have some upcoming webinars we wanted to mention. Our next one in July is resources to improve population health. So we are going to be releasing an interactive low value care report. We actually released the original report last March, which is horrible timing given everyone was very busy addressing the pandemic. And so I don't think it got enough attention. Low value care is a very low hanging fruit in terms of improving the quality of care for patients and reducing potential harm and lowering costs in Colorado. And then we'll also be talking about the information that's available in the community dashboard, which is very chock full of cost, quality, access to care information at the county and the Division of Insurance regions across the state. And then in August, we're going to be talking about ways that we can transform how care is delivered and paid for. The Medicare reference-based pricing analysis that we have, again, at the DOI and county level, and showing some of the trends in how hospitals are getting paid related to Medicare, and the data that we are providing to employer alliances like Peak Health Alliance and the Colorado Business Group on Health effort, the Purchasing Alliance for Colorado. We're very excited to be supporting those efforts. So we'll be sharing some of the information we're providing to them in August. So yes, we would love to take any questions right now that anybody may have, but feel free to reach out to us at any point in time at info@civic.org. Feel free to connect with us also on Facebook, LinkedIn, and Twitter. And then we will have that recording that we were talking about of this and all of the other presentations at our events and resources page. And we're trying to also put some of these and clip them out related to that particular analysis right on the page, so that if you're visiting that page, you could go straight to that section of this webinar. So we would love to hear from you guys. If I don't see any questions right now in the chat, so I think we'll stop sharing and thank all of you guys for joining us today. We appreciate your time, and we hope you have a good rest of your day.